Welcome here to UNE. My name is Shelley Cohen-Conrad. I am the director of the Interprofessional Education Collaborative, known as IPEC. You may have heard of IPEC before. There's a national IPEC, not to be confused with UNE IPEC, which came before the national IPEC, just saying. I'm really proud of today. It's a culmination of a lot of work we've been doing really since 2000. In 2010, we became a formal entity, our IPEC entity, a collaborative. And what we hope to do today is to showcase all the work we're doing here with our faculty and our students and our professional staff and our community partners and many of our partners across the country, some of whom are here today to present. So we want to give you the broad view of what we've accomplished since 2010, and to have you be inspired, to have you get excited, and also to have you meet each other. So one of the things I want to push for you is our lunchtime is really a time we're hoping you'll all network with each other and share ideas and think about ways that you can work together across campuses, across borders, across universities, across health settings. So, because that's how it works. I'm really excited to say we have people here presenting from all of our colleges here at the University of New England. This is truly a university program today, and I'm very pleased to have that happen. This is sort of a sidebar. I just want you to notice the front of your brochure. This is a piece of art that was done by one of our patient advocates who lives in California, who we've gotten to know very well. And what you'll notice is this piece here is a typical picture that is placed on the table next to a hospital bed. This young man has cystic fibrosis. He recently had a double lung transplant. He is alive today because of incredible technology. But this painting is a story about what happens when you're in the hospital almost more than you're out of the hospital, and that your picture becomes your vase, and your vase becomes the place where your flowers go, and where you become not just a patient, but an individual who has a powerful story to tell about the healthcare system. And so I'd love you to notice that, and also to take time during your breaks or during your lunch to notice the artwork that we have in the lobby, all of which is done by patients. It's a form of art called mail art, so all of the paintings and pictures that you see have been sent to us via a network of people who are wanting to talk with us about how to do healthcare better and how to do health education better. And our final plenary, we will have patients who will be talking and having a conversation with all of us, those who are able to stay, about how we can infuse patient voice into curriculum and how we can, again, teach our students how to change the healthcare system. I also want to say how grateful I am to the Macy Foundation, which is helped support in many of our efforts and is helping support today, and also to the Center for Excellence in Health Innovation, many of whom are here today as well. Wave, hi. And we'll be doing more in the afternoon. But the center really supports the clinical interprofessional programs that we have and has done a tremendous job in increasing the number of sites we have for students to learn that are interprofessionally oriented in many ways. And you'll hear more about that later. So before I introduce our provost, I have been told that I have to do housekeeping business. The bathroom is right outside there to the left. Every floor has bathrooms, and every floor where you be going to your workshops, ask the person who is the facilitator in your room to, if you need to do so, to show you where the bathrooms are. On your table are little cards Those are our evaluation tools. It's a method some of you know of called rapid cycle evaluation. We really, really want you to fill out those cards and hand them to people who might be wearing these little, Chris, do you want to hold one up? Yep, there. Yes, there we go. Who are wearing the IPEC buttons or who have the tags. We want to make sure we collect all of those by the end of the day. Marianne Lecomte, would you like to raise your hand? Is helping with CMEs. If you have any CME questions, I would direct you to Marianne. And I guess that's all the news. What I want to do before I introduce the provost is to say an incredible thank you. We are very lucky to have a phenomenal IPEC team who helped orchestrate this today. You will find that everything is pretty easy because they, behind the scenes, have done an incredible, incredible job. First, even though she's hiding in a corner and pretending like I'm not talking about her, is the amazing Chris Hall. Chris? This is the result of the work done by Michelle Cody, who has brought light and love and talent and brilliance to our IPEC office, and to all the members, and of course, Sally McCormick-Tutt, the leader of our team members who have helped to orchestrate everything from, the lunch to the programming to the signage to everything. Brianna and Allie, and the graduate students who are helping, who have assisted us. And if I've forgotten anyone, you can yell at me later. So it is my delight to welcome you. Come talk to me if you have questions about IPEC and what we do here. And so some of you have met our provost, Josh Hamilton, and some of you have not. But he's been here since April. And what a difference it's made. He is a huge supporter of interprofessional and interdisciplinary experiential learning. He is immediately become engaged in what we're doing, and we are very, very, very pleased to have him. So, Josh?
Thank you, Shelley. I'm really delighted to be here, and I'm delighted that you're all here for this inaugural showcase. This is really an amazing event, and I look forward to seeing this every year and having a really bright future for this showcase. But it also highlights just an enormous amount of work going on at University of New England and with all our partners in the area of interprofessionalism. I'm speaking to the choir here when I talk about this, but interprofessionalism is so important today in healthcare, and the broader idea of interdisciplinary education and practice is so important. And as much as we're emerging in this area and want to do more and better in this area, it's also very clear to us as we present at conferences, as we talk to colleagues elsewhere, that we have emerged as a national leader in interprofessional education and practice here. As much as we want to do more and better, we are already at the forefront, according to many other institutions that look to us for guidance for how to do this and how to follow best practices. It's very clear in healthcare today in dealing with patients that we need to take an interprofessional approach. It was for sure always that way, to look at the whole patient and to integrate that, but more so in the modern era of healthcare, as things have gotten more complicated, as we've had more technology, as healthcare professionals have professionalized more and specialized more. So it's not just physicians and nurses, but physical therapists, occupational therapists, social workers, a whole host of people coming together, not dealing with individual parts of a person, just focusing on their liver or their lungs or their arm, but focusing on the whole person and integrating their entire health experience in this way. To do that out in the health professions, we need to prepare our students to enter that world. And so the interprofessional education is really addressing that really important need within the health professions. And we're responding to that. But it's interesting that this came from the world that our students will enter as professionals. And we're being as responsive as we can be. And going beyond that and saying, well, how can we also innovate and advance and work with those partners to say, well, what's the next thing that we should be doing together for best practices? There's a broader concept of interdisciplinary education and practice that interprofessionalism fits within. So in the healthcare industries, you call it interprofessionalism. More broadly, in the other disciplines, we just call it interdisciplinary or transdisciplinary. I had a very early experience with this when I was running a research and education center at Dartmouth College, and we were focused in that case on environmental issues such as arsenic in drinking water, and we realized that we needed scientists, engineers, policy people, communicators, social workers, people in government. We needed a whole host of people to deal with that complex issue. It wasn't just a science problem, it wasn't just an engineering problem. It was this very complex social problem that also affected human health. And that really set the stage for me to really start thinking about this more broadly, that this is what universities need to do, and this is what we need to do when we go out into the world as professionals, is prepare ourselves not only to be deeply trained in our own disciplines, but to be very comfortable working with many other professions and sitting in teams, and depending on the nature of the problem, adjusting the complexity of those teams and who's at the table, but being able to work together, the blind people feeling the elephant, if you will, to put that picture together and really figure out the true answer in front of you, whether that's dealing with a very complex patient issue, or it's dealing with a social issue, or a population issue, or environmental issue. And so I really applaud the work you're all doing here. I look forward to all the wonderful things you'll talk about today, but recognize that you are also pulling together in this one day lots of activities going on across the university and with many of our partners throughout Maine and the Northeast region. And so you are at the forefront of this, and I look forward to UNE continuing to be a leader in this world. Have a great day.
Well, good morning. My name is Najeri Clark, and
my name is Lila Maycock. I am a second-year student in the social work department here at UNE.
And I'm a third-year student here at UNE in the College of Pharmacy. So before we get started, we want to thank you all for coming out and deciding to participate in what healthcare is actually about, and generally what it means to be a living human person, right?
Yeah, and another aspect of that is kind of talking about why we chose UNE and what our experience at UNE has been like so far doing interprofessional work. A big part of what kind of drew me in is that both of my parents are in the medical field. My dad's a general practitioner, my mom's a nurse midwife. And I always had a lot of kind of fear and stigma against medical professionals, which is weird, I know they're my parents, but I always had a certain amount of fear when I would go into a doctor's office or a dentist's office. And when I decided to become a social worker, there was a certain amount of that, of I'm gonna have to work with these folks, and I'm kind of scared of them. And I kind of believe that they know more than I do about everything, because they know about science and medicine. And so there was a lot of self-doubt, and there was also a lot of belief systems I had about how they saw me as a social worker.
And that has been the case, you know, here on the campus, having an opportunity to work with other medical professionals is when I actually started to find out what the task sets are and skill sets are and how to utilize each other. A lot of the fear that I've seen is that we don't understand the role of the other person sitting across from us. We don't understand the purpose and the skill set that they have. So it's difficult to trust something that we have no knowledge of, because it's just the nature of a human being. What you don't understand is what you tend to fear. But ultimately, we are skilled professionals that are there to remain patient-centered. And if we all have the common goal of helping someone live the best life that they can live, it becomes a lot easier to communicate and ask, well, what would you do in this situation? And the first time that happened was participating during a mini grant with social work. We sat there one night and we were debriefing, and it was like, oh my goodness, I had no idea that you knew how to read a medical chart. I had no idea that you understood diagnosis codes, that you are a active and working part of the team that is another check and balance for us, because it's not always about being right and it being my way. The collaborative is about helping the person that came to you for help live their best life. So remaining patient-centered was the focus. And what I've seen from social work and comm, I must say, from comm students as well currently, and that's not always the nature, I think the stigma that's given to medical professionals is that as far as medicine is concerned, allopathic and osteopathic, is that the thought is that I'm kind of like a food chain. That's what we were discussing, that there's a food chain, a hierarchy. But with the comm students in the room, we learned that the idea is that we are all here to help each other do the best work we can for the person sitting in front of us. That it's not about our own desire to be right or to be the best professional in the room. It's about the person that came to us for help. If that, and looking at that, we can head into the thought of the collective collaborative. Yeah.
Absolutely. And I think a lot of what you're getting at is the nature of the relationship between healthcare professionals. We talk a lot about client-centered or patient-centered care and how that should be what best practice healthcare looks like. And I think all of us get into these professions because we want to make a difference, we want to save lives, we want to see people living their best possible life. But a huge aspect of that is the trust. It's getting to know each other. It's getting to know not only each other's roles, but each other on a personal level so that there is a layer of trust. And I think about this past year, I was an intern at the Preble Street Teen Center. And it was an incredible experience. I was very privileged to be there. A huge part of what worked about what we were doing with that population was that we had several medical professionals who came in and volunteered their time. And I would be sitting there with a client who I'd built a massive amount of trust with, and then they would see me interact with one of those medical professionals with this relationship of trust, of friendliness, of camaraderie, and then they would in turn trust that medical professional. And that is what I think is so important, especially when we work with vulnerable populations, is to understand ways that we can build trust with each other so that there is a shared experience that is happening with you as the medical professional, with the client, and anyone else that you bring into your healthcare team.
Yeah, and speaking of the team, oftentimes we're concerned about patient safety, but the safety of the team is also another issue. Everyone on the team, in order for you to respect the person sitting in front of you, you have to respect the person sitting across from you, first as a person, and then as a valued part of a medical professional team. But if you cannot first see the person, you can't move forward. So a major part of that is just saying things like, good morning, how are you? How are you doing? Is making sure that there's team health as well as patient health. And that's the first step. So plug on the 21st, having those critical conversations are a part of team health. And they're not always easy, and that they're not always nice, and they're not always friendly, and they're not gonna end up the most positive way. But you have to make an attempt if your focus is to have the person sitting in front of you be a healthy person. If your team's not healthy, how can you help someone else be healthy? So it pushes itself towards creating a safe space for the team, ultimately taking a trust fall. I trust your skill set as a social worker. So when I send someone to you in need of services or in need of support, and you call me and say, oh, I noticed that something on their MedRec is not adding up. This may be adding to their situation. I take your professional advice seriously. I take your words seriously, and that respect will reflect in the patient having ease, and it will lower that level and threshold of anxiety that they may have with a white coat in the room or any set or team of medical professionals. And going back and forth, it also lends itself back to your leadership, how you look at being a leader from the top down. And on campus, you are our leaders. We will emulate you. Oftentimes, the thought process is, you tell your children, do as I say, but we know that we ultimately become our parents, we become our mothers, right? Unfortunately. And so we're not gonna do exactly what you say. We're gonna watch you more, the attitude, the mindset, how you operate and function with each other. It lends itself to the way that we operate, function, and relate to each other. In IPT, in expert, in every situation, that hierarchy, how you view yourself as a medical professional, we're watching. It's just like a child at play, right?
Yeah, and I think at UNE we have a ton of incredible role models who are very dedicated to the interprofessional experience. And I also, a huge part of it for me has been that clients see your interactions and need that trust. We as students see faculty working in interprofessional settings. If you trust each other, if we see you communicating, that's exactly what we're going to learn from.
Yeah.
And I think, another aspect of it that is really important to me is just going back to that idea of how do we truly keep putting the central value of healthcare first.
Yeah.
We have a lot of different pathways to get there as different healthcare professionals, but if the central value is the well-being of the client or the patient, then let's do everything we can to get there. Let's talk to each other. Let's admit we don't know everything.
Exactly.
Let's ask for help. And let's keep practicing those skill sets that we have better communication skills with each other. Yeah. So thank you so much for being here today. It's incredibly important for us to keep learning from all of you and for you to keep learning from us.
Thank you.
So now you see why we're so passionate about all of this. So thank you for giving us a little time here. My next job is to introduce our first plenary session, and it's from the Family Medicine Institute, and the title is The Deep Ecology of Patient Care. And I just want to say a few words. So these folks from the Family Medicine Institute were our first interprofessional clinical team that started doing this work with us, and we were just reminiscing about how so many years ago, how hard it was to even have a conversation at the same table with each other. We started the conversations 9 years ago, and there were a lot of obstacles, and there were a lot of ways of thinking about how we couldn't do it. And yet we did it. And we did it together. We did it as UNE faculty and administrators and FMI practitioners, and it has been going now for 7 years. Pretty remarkable opportunity for our students in an excellent, beautiful setting, to be doing home visits together in the community, to be learning with their patients, to be learning from each other, everything that Lila and Nagiri said. So, I welcome you to come to the stage and to start our plenary.
Hello, good morning. My name is Andrea Abrell. I'm one of the physician faculty at Maine Dartmouth Family Medicine Residency, and I work at the Family Medicine Institute. And I'm going to be sharing our story with you, along with Kelley Harmon, my physician colleague at the FMI, and Dan McCool, our wonderful pharmacist. And I'll explain the choice for the title as we go along. So this is our disclosure slide. We don't get anything extra for, okay. This is our official disclosure slide. So these are our learning objectives. I'm going to tell you the story of how our pilot program, interprofessional education with our students started, and hopefully give you some ideas about how you could incorporate this into your own practices, and some of the teaching methods that we use with our students. Dan's going to present some data on our research, and some literature citations. And Kelley's going to describe a little bit more about how interprofessional education has kind of filtered out into the rest of MaineGeneral education with our residents and other learners in our system. So the history of our program started prior to 2012, but I came on as faculty in 2012 when we really got the interprofessional rotation going. Please let me know if you guys can't hear me okay. So we really started the rotation with the students in a deliberate way in 2012. The concept started as a hospital-to-home concept. It was viewed that the transition from hospital to home for many patients was a very vulnerable time, and we had the relationship built with the School of Pharmacy. It seemed like an ideal time to work with both pharmacy and medical professionals in helping patients transition from hospital to home. There are always med changes. It's just a very confusing time for patients when they're discharged from the hospital. There are lots of handoffs that happen, lots of opportunities for miscommunication or lost communication. So it was seen as a really good time to try to bring in different professions to help patients with this transition. So we started with our third-year Unicom medical students that we have for a full year, and they do this IPE rotation while they're on their family medicine rotation. So it's really integrated into that for them. And then we also brought on pharmacy students from UNE and pharmacy preceptors. So for the pharmacy students, it's an ambulatory rotation for them, and for our med students, it's part of their core family medicine rotation. So one part of their rotation is clinic. This is our clinic. This is the Family Medicine Institute in Augusta. The Kennebec River is just downhill from here. So the pharmacy students and medical students see patients together with me and with other providers in the office. The pharmacy students get to observe the medical students doing physical exam, working through differential diagnosis, coming up with treatment plans. And the medical students get to see how the pharmacy students use research and treatment guidelines to make drug recommendations. These slides are a little mixed up here. Okay, so the clinic part of their rotation is seeing patients with me in the clinic, and we have our pharmacy preceptor available. As we've gone through the years and the residents and the other attendings have gotten to know that the pharmacy students are available, they've sort of been able to create this curbside consult service so that our residents can sort of just kind of consult the pharmacists on the fly, which has been really helpful for a lot of our residents, and I think Kelley's going to talk a little bit more about that later. Our pharmacy students also work with our MAs during one day of their rotation doing medication reconciliation, and we've also started integrating them into some of our geriatric clinics. We have a geriatric fellowship program at our residency as well, so the pharmacy students are working with those folks. The students have an opportunity to see a full spectrum at our clinic. We do lots of OMT, we do some procedures, we do medication-assisted treatment with Suboxone and Subutex, we do prenatal care, we see pediatrics. We have an immigrant population in Augusta requiring translators. We have a pretty large, low socioeconomic population, which presents a lot of challenges, and lots of chronic disease, pain, diabetes, COPD, heart disease. Right. Okay, the home visits. This is everybody's favorite part of the rotation. So on Wednesdays, we do home visits, and we have another provider that does some home visits in the mornings, and I do home visits on Wednesday afternoons along with Dan. And the way these start is we have a nurse that we've sort of championed to be our scheduler. The scheduling for these visits has sort of evolved over the last 6 years, where we started out with an intention to see patients who were discharged from the hospital. We would have pharmacy students go and meet some of our patients in the hospital and talk to them about what we could provide. It's evolved a little bit over the years, and now we see patients for a variety of reasons. We often see people who've been discharged from hospital or nursing home. A lot of times residents will ask us to go see people because they're concerned that there's polypharmacy going on and they'd like some recommendations about what they might be able to eliminate, or they're concerned about drug-drug interactions. Sometimes we're asked to go see people because they're concerned about medication compliance, or they don't know if the patient understands how to take their medication appropriately. Sometimes patients are homebound, so a home visit is really helpful. We had one visit we did on a patient who had an opiate addiction problem, and he was afraid to leave his home. He was afraid to go out and drive by a corner that might be a trigger for him, so we did a home visit for him. We've seen patients who have had strokes and they live on the second floor of an apartment building, and so it's really difficult for them to get out. We were asked to go see one patient because the resident knew that he didn't know how to read, and he couldn't understand how he was taking his medications appropriately. So we went to see him and figured out that he had this sort of elaborate system of slash marks and symbols that he would put on the bottles, and he knew which medicine to take when, and but we wouldn't have known that if we hadn't gone to see him in his home. Last year, we added a third learner to our group. We started having a psychology student. The student is with us for a year. We're going to have our second psychology student starting this next week. So the student that we had last year started coming on some of these home visits with us as well, which was really, really interesting. So these home visits, this interprofessional home visit with the pharmacy available, with the psychology available, has just become more known at our clinic now. It's become part of the culture, so it's become a lot easier and more natural to schedule these visits. All right, so this is how we do it. So as I mentioned before, our nurse calls patients, tells them what we have to offer, and gets permission. We get permission when we go and visit the patient. This is really important because we are a group of people. So we ask permission to come in and look at their medications and talk with their family and be in their home. We try to utilize the strengths of our team members. So our pharmacy students and Dan will often kind of split off in the beginning and go through the patient's medications. And the medical student and I will sit and talk with the patient, get some history, do some physical exam. Sometimes we'll do sort of a staggered arrival, especially when we have our psychology student with us. Last year, our student would go to see the patient first and kind of have a few minutes alone, or maybe just with one of the students, to talk with the patient about what their goals were for this visit. And then the other pharmacy student and I and the medical student would arrive a few minutes later. And that was really helpful to have her talk with patients and really kind of get at what they're interested in, what are their concerns, what are their goals for this visit. We try to do a lot of teach back. The pharmacy students are really excellent at having patients teach back to them how to take their medications, how to use their inhalers. And then the medical student and I as well can do some teach back with diet, lifestyle, recognizing concerning symptoms. One visit that we did a few years ago, I thought shows a really kind of fun example of teach back. We had Dan and a couple of the pharmacy students and our medical student, and we were going through the patient's medications, and somebody kind of knocked the med box and it went onto the floor, meds scattered everywhere. The patient was not miffed at all by that. It was an opportunity for him to then show us that he knew how to put his medications in the med box in the appropriate order, and it turned out to be a really great experience for everyone. Communication with other members of the patient's healthcare team is very common during our home visits. A number of times we will call the home health nurse, or if they're going to the Coumadin clinic, we'll call them. They might have home health PT, social workers, case managers. I really try to model that communication in front of the students and calling people and getting their input on what's going on with the patient. All right, so I'm just going to share one of our home visit cases with you so you can kind of see how it plays out. So KM is a 71-year-old male with COPD, depression, cervical spondylosis with chronic musculoskeletal pain, nicotine dependence, alcohol abuse. He had a diverting colostomy after a partial colectomy from a perforated diverticulum of the large intestine. I forgot to put on this slide, he'd also had a stroke a number of years ago and had some residual left-sided weakness. So in March, this past March, we were asked to go do a home visit with him. He'd had a fall and had gone to the ER, and his wife and he were living with their daughter in her apartment. So through chart review, reviewing the ER note, talking with the patient's PCP, we were able to kind of identify what we thought the major issues would be. His depression was not being treated. He had been prescribed something, but he wasn't taking it regularly. He'd had a recent relapse with alcohol that we thought had contributed to the fall that landed him in the ER. He was having problems with pain and weakness. Nicotine dependence was preventing him from getting the go-ahead from surgery to try to reverse his colostomy. And they were essentially homeless. They were living with their daughter. It was supposed to be a temporary situation. She had a very small apartment. He and his wife had been evicted from their apartment for smoking. So that's why they were living with their daughter. And the homelessness piece of it, was really a big factor. It was causing stress for everybody. I think the daughter had some medical issues herself, and it was contributing to his depression and quite likely his relapse with alcohol. So organizing the visit, we had our psychology student with us for this visit, and she started out by talking with KM's wife and their daughter about what their concerns were, how it was going for everybody. And I think I mentioned before, just organizing the visit is really important because there is a group of us. There's anywhere from 3 to 6 of us, depending on if we have 1 or 2 pharmacy students, if we have the psychology student with us. So we try to organize it a little bit so it doesn't feel as imposing for patients. So our psychology student, Jenna, talked with KM's wife and their daughter. Our pharmacy student and preceptor were able to go through his medications and think about what might be appropriate medications to recommend for his pain and depression. And the medical student and I talked with the patient, got some history, did some physical exam. This medical student happened to go through the expert training, so he was able to use that to talk with our patient about his willingness to work on the alcoholism. And then we all come together with the patient and their family to make recommendations. Our recommendations included restarting the bupropion that he had been prescribed previously, and we added on mirtazapine. He was having some difficulty with sleep, and we thought that might help him with that. He agreed to trial some Lyrica for pain and was open to having a PT referral. Our psychology student was able to call back to our clinic and talk with one of our social workers to arrange a meeting for KM's wife to talk with them about some housing options. And then we also communicated with our MaineGeneral CCT team, community care team. This is a team created by MaineGeneral that has a very similar mission that we do. They have an RN, a social worker, I think they have a nurse case manager, and at discharge, patients are identified that might benefit from this type of team as well. So he had been referred to them, so we communicated with them about our findings and what we thought might be helpful. And then we made a referral to an outside surgery group for a second opinion about the colostomy reversal, which made him pretty happy. After the home visit, we debrief with each other, oftentimes in the car ride home or back at the clinic. And then we divide up the tasks, whatever follow-up tasks, if it's talking with our social workers, making some calls about medications, whatever it is that needs to be done, we kind of divide that up and work on it. So our students are learning from each other by seeing patients together and being encouraged to be equal members on a team. By working together as students, they will be more likely to seek out each other later in their professional life. I think our students that helped to introduce us demonstrated that, and work more collegially in pursuit of the best patient care possible. So I have a little bit of follow-up from that case. A month after our home visit, the patient presented to the ER requesting inpatient alcohol detox. He and his wife now have their own home in a neighboring town. He continues on the mirtazapine, has been switched now to sertraline from the bupropion. He did have that second opinion surgery consult, and the plan was to proceed with colostomy reversal. He's still contemplative about smoking cessation. How we learn from each other outside of these patient visits. So Dan is really awesome at when we have a new cohort, our students are staggered a little bit. So we have our psychology student for the whole year. We have our medical student who's on an 8-week rotation, and our pharmacy students who are on a 6 to 8 week rotation as well. And they're usually staggered a little bit. Our rotations don't line up perfectly, but it works well because the previous student, medical student or pharmacy students can sort of orient the next set of students that are coming. But when we have a new cohort that comes together, we do this little activity where we share something interesting about ourselves, where we're from. We'll often do this in the car on a ride to one of our first home visits. We get together around food. Dan makes an awesome oatmeal casserole, and he often will bring that or something else in on Tuesday mornings when we're seeing patients in clinic together. It also brings other people around the clinic in because they want to try the food as well. So it brings in residents, other attendings, some of the MAs and nurses, and just kind of creates more of a community and collegial feeling. We have our students do some reflective statements during their rotation. I think writing forces you to think more about your experiences, and Dan's going to share a little bit more about our students' reflections later. Last year, when we added on our psychology student, we started doing these Thursday sessions. It's 1 hour where all of the students get together with the psychology preceptor, Dr. Corey Smith. They start by reading an article about patient-centered care plans and discuss the roles of each professional in the care of the patients. Then they explore their understanding of each other's process of education, training, licensure. This is seems like a simple thing, but it's really enlightening for students to for a medical student to learn what does a pharmacy student do? How do they learn? And vice versa. And then during the rest of their 5 to 6 weeks together, they choose and complete a patient-centered care plan for at least one complicated patient. It's usually one of the home visit patients because that's who they all tend to see together. Kelley's going to talk a little bit more on how we've integrated interprofessional education into our resident didactics a little bit more, and how the pharmacy students have been able to participate in teaching during that time as well. All right, why Deep Ecology? I was raised by a librarian and a biologist, so I grew up with an appreciation for knowledge from various sources, awareness of the interconnectedness of nature and the world. My undergraduate degree was in human ecology, which is the study of how humans interact with their environment, and I'm an osteopathic physician, so I see the body as all connected. So I see the world through this lens of connection. So naturally, I see healthcare as an interconnected web of ideas and people that work better when we acknowledge those connections. So I drew some analogies between the tenets of deep ecology and our work. All living beings have intrinsic value, and I believe all healthcare professions have intrinsic value. Diversity of life forms contribute to the realization of these values. PT, OT, social work, nursing, physicians, PAs, NPs, pharmacy, psychology, patient and family all contribute to the patient's health. Humans have no right to reduce this richness and diversity except to satisfy vital human needs. And in most cases, unless there's a code or something, which actually codes are very team-oriented as well, in most cases it's not helpful to work in a silo. So I think working in an interprofessional way makes you more aware of the social determinants of health. I feel like if you're asking the social worker what their thoughts are on this case, you will most likely become a little more aware of the patient's income or financial restrictions, transportation or legal struggles. The home health physical therapist can enlighten you as to how the patient is doing in their home. Your psychologist or your licensed clinical social worker can enlighten you about the patient's education level, their ability to understand medical reasoning, or your nurse or your dietitian might have some insight into patients with food insecurity. And patients like it. Patients appreciate when the individuals involved in their health care collaborate with each other. I can't tell you the number of times patients are just wowed at the fact that a pharmacist is coming with us on this home visit. We have a greater sense of satisfaction. I could never work in a solo practice or even a small physician practice. I think professionals, I think we all have a greater sense of satisfaction if we work with each other. And students really like it too. They learn more deeply about what good patient care looks like. So now Dan's going to talk about some of our data.
Thanks, Andrea. I'm Dan McCool, and it's really a delight to spend about 50% of my time allocation at the Family Medicine Institute and the Maine Dartmouth Family Residency working with the team there. We gain a lot of satisfaction in different ways. I have a great deal of job satisfaction, if you will, because I have a meaningful relationship in a learning and co-participation community. My patients get satisfaction. I'm learning all the time, and it's okay that I don't know all the answers because I work with a team, and together the team is able to figure out answers for our patients. So my job today is to bring you some of the research and talk about what's going on in interprofessional research. So This was an IRB guided study, which I served as principal investigator. And we had 3 main research questions. We really wanted to know how medical and pharmacy students describe their learning about other health professions. And we wanted to know what experiences contributed most to their learning and collaboration. And then lastly, we wanted to know how this collaboration ultimately benefits patients. So good news is if you look in the literature for interprofessional education and collaboration, you're going to see some really great news. And I didn't give you a formal literature search. I'm just going to summarize some really nice themes that are going on in there. So team orientation in healthcare is really well described in the IPEC panel that came out in 2011 and was updated in 2016. Tremendous resources there about the value of team orientation in healthcare. Interprofessional education and collaboration fits perfectly and supports the triple aim, and that's really the basis for our national healthcare reform. It improves access, quality is improved, and ultimately the patient experience. So at the end of the day, we want our patients to have the best experience possible. Good news is that now accreditation standards across all health professions learners have an interprofessional education component, which is fantastic. So if you're on the academic side, you're really doing the work to prepare students ultimately for collaboration. And if you're in practice, well, guess what? You get the benefit of getting learners ready for those kinds of activities. And then the World Health Organization really laid down the mandate back in the 80s for the need for healthcare reform to reflect and value interprofessional education and collaboration. So it's all good news. So our study was conducted from 2013 to 2016, and we've had actually, now we've continued the research beyond this time, but the formal research was with 60 students, and we don't have a cast of thousands. We have 2 pharmacy students and a medical student learning together, and they're typically around 6-week rotations and longer. And the research and the teaching was guided through a faculty pharmacist and a faculty physician. So we used 3 instruments that are well described in the literature, and I'm going to talk a little bit more about them. We started with one, and then we saw what the results of that one instrument was, and then we changed instrumentations in the way we were studying. So we did learn some things, even though all of the numbers didn't tell us everything we wanted to see, but it helped us guide and refine our program a little bit. So the first instrument we used was called the Attitude Toward Healthcare Teams, ATHCT, and we used that for about 2 years, and we used it alone. And it had some open-ended questions on the end. And then we switched instrumentation. We used 2 instruments. So at the beginning of students' rotation, we asked them to fill out this survey and rate these items, and it's a Likert scale with about 10 questions on each instrument, whether they agree or disagree with those items. And then we also used the team skills scale and SPICE tool together. And I'll talk a little bit about what the SPICE tool is, but it's specific toward pharmacy and medical education together. But we knew we were going to have other learners present, so we used the team skills scale, which is also a validated and vetted instrument that's used worldwide. All right, so this is a nice visual depiction. We were really excited about using ATHCT when we first started. It was well described in the literature. It's used worldwide. The Canadians had used it. The UK had used it. And we used it. And then at the end of 2 years, it didn't show any statistical significance across the instrument. So we were scratching our heads thinking, okay, what's going on here? And we just looked at it from a more practical lens. So thanks to the efforts of the IPEC, the center here at UNE, and all of the work that you as faculty are doing to prepare your students, we realized from the comments that students were making, they were really well prepared to come to clinical practice ready to collaborate. So guess what? They, I hate to use this analogy, but they drank the Kool-Aid. And so they knew, okay, we're ready for this. We're totally ready to go. So the instrument itself quantitatively didn't show us anything, but we got some great information, some rich, thick information from the open-ended questions that we asked when students were allowed to tell us about their experience beyond just rating simple items on a survey instrument. So we'll talk a little bit about that more. So here's for those of you that are stats folks, you'll see the good news or the bad news, if you will. So pre and post, which is the start of the students' clinical experience, they took the survey at the end, so that's the post data. They took the same survey instrument, and 6 weeks later, well, there was overlap, so it didn't tell us anything. But we did find out some really nice things that they were telling us in terms of the themes, and we grouped those themes, and we realized that our students really came to understand and appreciate more the roles of other healthcare professionals and their scopes of practice. That was the major theme that came out of that, those themes. They had quite a substantial increase in terms of their understanding on what the impact teams can make on patient outcomes, because ultimately, remember, we want to know not only from the educational side how this challenges our students, but what do patients actually get from this. And a few students described, and maybe this was because it was early on, that there were some challenges. I think we were probably getting our act together when we were trying to figure out how do we schedule and coordinate, a team of 5 or 6 people coming to a patient's home, and how do we work out all the logistics. So there was probably a little bit of that, and fairly enough, we used that for programmatic improvement. And then, interestingly, our students tell us that they had an increased confidence or ability or the skill set necessary to reach out and then begin collaborating with other healthcare professionals. So thematically and qualitatively, our students did get something, even though the numbers didn't tell us, wow, these students really had changed attitudes and perceptions. But they were already raring to go. We moved to the SPICE tool, which is about specifically for medical students and pharmacy students working together. And we only used that instrument for about a year. So we don't have, again, a cast of thousands, but the instrument did tell us a couple really neat things, particularly, again, about roles and responsibilities. So if you look at and I'm sorry it's a busy slide, but I'm a visual guy and I like to show things visually. But if you look at the bottom, you'll see that domain had statistical significance across the instrument. So I understand the roles of professionals working within the team, and my role within the interdisciplinary team is well defined. So students really got that in terms of a change working with a medical student and or a pharmacy student together. So here's the numbers analysis for those of you that are the stats folks in the audience. You'll see that there's statistical significance across the domain of roles and responsibilities. And I think that is really telling of the work that we're doing as healthcare professionals and faculty. We're emulating those professional attitudes and behaviors for our students, and they're seeing that, and it's showing up. Okay, one more quick visual. We also used an instrument called Team Skills Scale, and this is not specific to any one discipline. It can be used across health professions learners, and it's really about how the aim of the instrument is to figure out how well teams are working together. So you can use it with social work, with pharmacy, medicine, PTOT, you name the team, and you can use this instrument. And for those of you that, again, that are statisticians, when you look at it, here's the mother load. This showed statistical significance across the whole instrument. So we saw this data and we were like, yippee, okay, something really cool is going on here in terms of what students are seeing across teams. And so it's not only how well, teams are functioning, but it's also about the patient experience and that interface with them working together. So it's not just them working together as a team, but it's working in the actual clinical experience with a patient. And that's why we were like, yippee, this is telling us something. All right, so here's the data analysis. So no overlap across the whole instrument. You can see pre and post. So the intervention obviously is the 6-week rotation of teaching time. So pre and post, they took the same instrument survey, and with the difference of the post survey had some open-ended questions where the students could really tell us some things, and I'll try to elaborate a little bit in terms of what the students are telling us. All right, so quantitatively, these are the items that came up as statistically really significant. Let's see if I can read a couple of these because the print may be a bit small. So the students were able to function effectively on interprofessional teams. They were able to raise appropriate issues at team meetings, and we often find that when various health professionals are working together, people are afraid to address the elephant in the room or talk about things that are really critical in terms of the patient. Students were able to recognize when the team is not functioning well, and that gets at the health of the team. So when students can not only work together, but they can see when somebody is not functioning to their ability, they can fix and correct as they go. And you'll notice the last item, help draw out team members who are not participating actively in meetings. So students get comfortable enough with their experience that they can actually talk to each other and draw them back into the conversation. So that is meaningful in terms of what we're doing on the educational piece. All right, so I want to read to you the voice of the students. And this is what they told us through reflective statements and also through the open-ended questions. What surprised me most was how easy it was to get along in a team and work together to ensure patient care. I guess I thought it was going to be harder to work as a team than it actually was. And another said, I was surprised by how natural and often effortless the collaborations were. Another student said, I also learned a great deal about what services other healthcare professionals provide and how to best utilize their resources in the future. So that talks about practice intention changes. Another student said, I more fully understand the role of pharmacists and their knowledge of medications. I've learned that pharmacists can play an important part in patient education in providing counseling, discussing appropriate use of medication, side effects, and interactions. I guess that was a medical student. I feel more confident working in a team, one student says, and I have really seen the differences that working in a team can have on our patients. And in select populations like those seen at the FMI, I feel like drastic improvements were made in patient care. Another student said, I'm convinced that more was accomplished because we coordinated together than what would have been done had everyone simply worked individually. And another student said, and now I'll be more likely to call the other profession for consultations, questions, opinions, and ideas. And another student writes, after my IP experience, I now view pharmacists as primarily healthcare providers. Another student said they value our opinion and engaged us in conversations. We valued them and they valued us, and it allowed us to work well and effectively together. Another student said, patients feel as though you are invested in their health, and not just in one area when they know you are collaborating together. They are more willing to bring up and address their needs that they may think you were previously uninterested in hearing about that may be vital to the overall process. And another student writes, I want to emphasize that the home visits were the most influential and educational component of the rotation. And then lastly, this rotation strengthened my abilities to collaborate and consult with other healthcare professionals. So that's what our students said about this experience. All right, so concluding in terms of our own research, the attitudes toward healthcare teams quantitatively didn't say anything, but what it did tell us, the story behind the story, is our students were ready. They came prepared. Thank you for all of your work as faculty, because the students are ready and raring to go. They really gained an appreciation for the roles of others, and they really had confidence to reach out and talk to other healthcare professionals. And particularly, they gained an understanding for the impact teams make on patient outcomes. And then lastly, that the home visit, they told us this not only through these instruments, but face-to-face, they would tell us that these home visits were the most influential aspects of their learning together. So it was learning and co-participation. And I'll just summarize by saying, and you may pick different instruments as well, but we found that roles and responsibilities were really a key thing, a key finding, particularly for the SPICE tool, so students really gained something from that. We saw that, and this backed up our supposition, that the clinical practice experience, whether it was in the clinic or the home visit, were the ideal place for medical and pharmacy students to work together. So while they appreciate the didactic piece, they really wanted to get it in application. So that was meaningful for them. And that ultimately collaboration, so here's the proof in the pudding, benefits patient outcomes. And then ultimately, the patient care is improved because there's this collaboration, there's informed decision making together as a team as a result from that collaboration. All right, so next I'm going to turn it over to my colleague, Dr. Harmon.
Thank you, Dan and Andrea. It's been a pleasure to work with both Dan and Andrea over the last several years. And some of what I'm going to be summarizing in these last couple of slides is just a little bit of our experience. When we started to have these initial conversations, I can tell you they were not easy. As Shelley mentioned, we certainly sat at tables and racked our brains about how we could actually put some of these important skills into practice. And of course, finance has always come into play, and scheduling and time and clinical resources were really some of the biggest barriers that we had. But we were able to take what was maybe a much larger plan initially with many health professionals involved and narrow it down to the pharmacy and medical professionals as a start. And that was a great way for us to be able to build upon the work that we've now been have been able to do successfully at Family Medicine Institute and our residency program in our hospital system. And I think that one of the reasons that it has been successful is we knew from the start that we were a perfect fit for interprofessional education, in part because we were already doing this work. It was very much a part of sort of the training that is happening at our residency program, and Andrea and I are both graduates of both UNE, COM, and Maine Dartmouth Family Medicine Residency Program. So we've had several conversations over the years where we've just said, what's the big deal about this? Because this is sort of what we have been doing all along. But the difference is we were starting to be deliberate about calling it what it was, and be deliberate about creating some structure around that so that people did understand what they were learning. And what was really nice is that culturally at the Family Medicine Institute, our clinic at the residency, it was fairly embedded in the culture to pick up the phone and talk to the pharmacist, or pick up the phone and talk to the therapist, to work with the social workers. Dan Onion and Jim Schneid and Alex McFedrin and some of the physician leaders at our residency program had embedded social workers within our clinics because that was what our patients needed years before. So I feel that it was just ripe ground, and that was part of why we've had the success that we have. We're also a full spectrum primary care training program, and that has lended us to have our fingers in a lot of different areas within the hospital system as well. So MaineGeneral is the hospital that we're associated with. It's a community-sized hospital, and I think that because we're small enough but big enough, it's also really helped us to engage interprofessional education in a way that maybe some larger systems might have some difficulty doing. We have many learning opportunities across different professions. We have a large number of learners within our system, and they're not necessarily in equal amounts. So we have a huge number of nursing students, and I think most hospital systems do. A smaller number, maybe just a handful of therapy students over the course of the year, a pretty large number of medical student professionals. But we have medical students, medical residents, fellows, but we really have some education present, but we don't really have a Department of Medical Education that directs all of this together, so it's not necessarily coordinated. And I think most community level hospitals certainly would have some of those same challenges. So these are the learners that are present in our system at MaineGeneral. We're just under 200 beds as far as the size of our hospital, but you can see we have a number of learners. And again, the majority of our learners are going to be our 3rd and 4th year medical students, our family medicine residents, our NMM+1 fellows, and then we happen to have sports medicine, geriatrics, and ER fellowships as well, which is a wonderful addition to our learner group. Our pharmacy students, we also have pharmacy residents, so our pharmacy students come from UNE, and residents come from Husson, so we're able to integrate all of them. And then physician assistant, nurse practitioner, again, therapy student, social work, psychology. So many of these learner populations are in much smaller numbers. So what we've tried to do is be creative beyond some of the formal education that you've heard Andrea and Dan talk about with the pharmacy and medical student, and now psychology student rotations. We have tried to open up the existing educational opportunities that we have within the hospital system that's driven by the residency, and invited in some of these other learners that are just within our system. So many times the things that I need to teach medical students or residents about COPD, a therapy student certainly could benefit from that, a nursing student could benefit from that, our PA and NP students. So there's lots of examples of folks that can really both benefit from the information and offer back some of the things that we may need to know in a different profession. So we've certainly tried to do that. And this is just a list of some of the formal and informal ways that this happens within our system. They talked about the home visit curriculum. We also do Tuesday afternoon education regularly, and that's a kind of easy way to invite other professional learners into the mix within our residency training program. Skills labs and procedures. So our pharmacy students actually do the flu clinic for the medical students that need their flu shots. When they go out to rotations, they are learning. Dan helped with a ACLS, a code presentation just recently with our medical students. There's case discussions, there's bedside rounds, all of these things lend themselves to multiple types of learners. We did have a large geriatric case that we did a couple of years ago. We're hoping to do that again, and that was a much more formal interprofessional afternoon where all different professionals were represented, and then the learners that were in the system at that time came to that program, and then we set up an opportunity for them to work in small groups on a geriatric case that had lots of variables that were really relevant and made very big differences in the patient's care. And then on the right, this is a little more of the informal kinds of things that just sort of happen when students are out on their rotations clinically. Curbside consultation, which Andrea talked about a little bit. Just the presence of Dan and the pharmacy students in the clinic is remarkably helpful. It lends to efficiency. It helps with people getting a lot of job satisfaction because they have somebody to ask a quick question to quickly. And then again, interdisciplinary rounds just exist in hospital systems. So all of these rotations, ICU, medicine, psychiatry, pediatrics, are places where these things are happening regularly for our students. And I'll just end with the tenets of osteopathy. I'm a DO, born and raised here, and just a reminder that these 4 tenets, for those of you that might not be as familiar, the body's a unit, the person is a unit of body, mind, and spirit. It speaks to holistic medicine, speaks to looking at the person as a whole, and interprofessional education really lends itself to doing that. And then there are 4 tenets. I think these are the 2 that stand out the most. Structure and function are reciprocally interrelated. When we were trained, we certainly are thinking about that for an individual patient and how their body mechanics and what we can do to kind of help them function best is going to be impacted. But again, IPE really lends itself to this. If you think of structure and function of a team and how important those different players in the team and their interrelation can impact a patient's health, you really get a lot of benefit. So I'll leave you with that thought. We might just have a minute or 2 for questions, and we'll be moving on to the next part of the afternoon or the day.
It's a real pleasure to be here, and welcome to everyone, those of you within the UNE community and also all of our guests and partners from outside the immediate area. So thank you all for coming and making the time to come here today. So a few years ago, I'm trying to think of how many years ago it is now, maybe about six or 8 years ago, my daughter was hospitalized at a hospital in Philadelphia and it was a tertiary care hospital, great hospital. Turns out she had septicemia. It was, pretty serious and of unknown origin, but she was septic. And so, of course, I rushed to her side and stayed there as much as I could and tried to, see what was going on. And what I was shocked by, and this won't come as a shock to most of you, but having not done inpatient work for quite a while, I was shocked by the experience in that we'd have a physician come in, do an assessment, write a couple orders. There'd be a consult would come in, do an assessment, write a couple orders. Another one would come in. Then we had folks beyond the physicians. We had nurses. We had various therapists of various kinds come in, and no one was talking to anyone. It was as though they were dealing with this disembodied person, all different organ systems independently, and there wasn't coordination. And it was only through the advocacy of the family, really, that we were there saying, wait a minute, let's connect the dots here. What is this person saying, and what is this person saying, and how does this all fit together? And I shudder to think what would have happened had there not been an assertive, somewhat savvy family member there to kind of force people to connect the dots. I realize that IPE and interprofessional practice go way beyond that isolated experience, but I just give that as one example of a very poignant example that I can point to personally for the lack of understanding and the lack of coordination and the lack of a team-based effort and the impact that it had directly on my family. Now the good news is my daughter recovered, she's doing great, everything's fine, but it was a pretty scary experience and it was a real eye-opener for me. So lo and behold, when a little bit later I had the opportunity to learn about UNE, I knew about UNE kind of in the background, but I admit that I didn't have deep knowledge of the university, and one of the first things that I discovered as I started researching it was our excellence in IPE and all the efforts that have been made over the past decade in this space. And it was incredibly impressive to me, resonated very deeply with me, both sort of intellectually, but also at a personal level. And of course, being a psychologist, where we tend to look at things, or at least we try to look at things more holistically, it also resonated from a professional perspective. So I couldn't be more thrilled that UNE has stepped up and is taking a lead nationally in efforts with interprofessional education. I have to say this is something that we all here feel very passionately about. It's reflected in the fact that one of the first things I did when I assumed the presidency a little over a year ago was charge a task force with looking at the future of interprofessional healthcare and what steps we could take. That task force worked very hard, very diligently over the past year for several months and issued a phenomenal report that really sketches out a plan going forward. That work is also reflected in our new strategic plan. So we've been engaging in a year-long process, a strategic planning process for the university as a whole. And we're just now at the very sort of end of that process. We're getting lots of additional feedback from the community, and then we'll put the final touches on it next month, and it'll go before our Board of Trustees for approval in November. And in that task force, interdisciplinarity writ large is highlighted, and interprofessional education in the clinical sphere and interprofessional practice, which go hand in hand, is likewise highlighted as a prominent part of our new strategic plan. So this is something that is a big part of the DNA of UNE, and I'm really so grateful to all of you for your work in that, for being here, trying to learn about it, for all the presentations and the efforts to advance this. It's just absolutely wonderful. I also would be remiss if I didn't thank the Josiah Macy Foundation for their support of today's conference and their support of our IEP efforts more broadly. I was honored to be here when the head of that foundation came earlier this year and did a presentation and had a conversation with us, and that was terrific. So again, thank you all for your commitment. Please keep up the good work, and let's take this to even bigger and better levels going forward. Thank you.
Good afternoon. I know in your program it says Dora Ann Mills will be speaking next, but unfortunately she couldn't be here, so I'm here in her place. My name is Toho Soma. I'm a senior research associate who works with Dora in the Center for Excellence in Health Innovation. Just a little bit about our center in case you aren't aware. We're about 2 years old now. We're based over in Linnell Hall. Our mission is to take the interprofessional skills students learn on campus and apply them to community and clinical settings so that extends the thread of IPE through graduation. We also run the Care for the Underserved Pathway AHEC Scholars Program and coordinate our very popular Rural Health Immersions program, where an interprofessional group of students and faculty spend a few days in a rural part of Maine to learn about the healthcare system there and the culture and people there. So now it's my pleasure to introduce our plenary speakers for this afternoon. First, Dr. Felix Hernandez is the Director of Undergraduate Medical Education and Physician Advisor for Perioperative Finance at Eastern Maine Medical Center. And joining Dr. Hernandez is Frank Bailey, who is a medical educator also at EMMC. We're so proud to partner with EMMC. They're, again, one of our first clinical settings where UNE students had the opportunity to transition from interprofessional education to interprofessional clinical practice. And so please welcome them as they lead us on an interactive session around implementing best practices.
Good afternoon. One of the things I may ask is for all of you sitting alone in chairs to find a way onto a table so you can work with the people at your table. Because this is going to be an active learning experience. Slide is important. This one is. You can get CME credit for this session, so please do so. This one is not so important. We have no conflicts of interest. We don't get paid anything by anybody for anything like this. All right. So by the end of this session, we hope you guys have some ideas about how to begin IPE student activities where you are, whether you're an educational institution or a clinical site or something in between there. We hope you'll be able to identify some of the opportunities you have and prepare for some of the challenges you're going to meet in doing that. And we want to share with you our dream of how we think this has the potential of transforming the way medicine is practiced in the coming midterm and far future. So we're going to talk about best practices in a different way, because we're going to talk about how do you begin to think about this, how do you establish a program, how do you study its effects, and how will this transform medicine? Oh, went the wrong direction. So you all have one of these at your table. We encourage you, or many of these at your table, hopefully. We encourage you to use this to jot down some notes as we go along. So begin. Where to begin? And I'll tell you a little bit about our story. We attended a session something like this 5 years ago, hosted by Dora and a couple of people here, and by the Josiah Macy Foundation, where we sat around the new fancy classroom at UNE, and we were all told to design an IPE program at our institution, and we had seen a presentation by Kelley's group. And I had somebody from family medicine and some pharmacists with me, and some people from Beacon Health. And so we started out this way, and I've had enough chance to think about it to sort of systematize it and based on Kelley's thing. So a good place to start is take an inventory of what you have at your institution for health professional students and allied health professional students, and write that list down, okay? And then the next thing you go to is to start thinking about, well, where are those students naturally bumping into each other now? So you can see what I'm getting at. I'm looking for the easy way to establish this. I'm looking for low-hanging fruit. And that gives you an idea of who the champions are that you need to bring to the table to put this program together. And I do want to take a moment to talk about this item of multi-professional versus interprofessional education. One of the challenges we've had is that a lot of our physicians think that we are practicing interprofessional medicine. And based on my experiences with our students, we really aren't. We're practicing multi-professional medicine. So we have an internist that sees a patient, we have an ID person that sees a patient, we have physical therapy, but they're not in the room together interacting with the patient to come up with what's the treatment plan going to be. And when you put those skills together in the same room, what? Okay. When you put those skills together in the same room, what you notice that develops is a synergy that's really quite magical and quite powerful, because they start feeding off each other and bouncing ideas and taking the last idea they heard and carrying it a step further. And that's the wonderful thing about interprofessional care. So I think it's important when you do these exercises to put these skill sets in the same room at the same time so that they can interact. It's not going to work as well if they each do their work separately in their own offices or in their own areas in silos. So when you do that, when you have your inventory and when you have your champions and you know where they're bumping together, you can then identify what kind of patient interactions could occur that could benefit patient outcomes. I will say that one of the differences in our program from Kelley's shows up in our personality, that her presentation was all about clinical and patient stories and stuff like that. And I tell our medical students that the clinical outcome is purely secondary. That the reason they're in the IPE program is to learn about team function and how high reliability teams work, and what their characteristics are, how to recognize when you're not in a high reliability team, and how to correct that situation. And it comes from the fact that these guys are primary care physicians and I'm a surgeon. So I'm more interested in the team. The clinical benefit is important, but it's secondary. Establishing your program. We talked a little bit about this, a useful purpose, and I would say that purpose has to be useful in the eye of the students. One of the powerful things we have is we get students from UNE, School of Pharmacy, School of Medicine, and they've all had some IPE training, but when you send them on a home visit, and there isn't a pharmacist with them, and there isn't an attending primary care physician with them, there's a nurse or a social worker that's a facilitator, and they have to assume the responsibility of those roles. It becomes very real and very powerful and very useful to them, and they start to really develop their professional identity. So putting them in the, now granted, these people are not out there practicing medicine without a license. There's a primary care physician that they're bouncing things off of. There's a licensed pharmacist that they have to bounce their ideas off of. But at least as far as the patient visit, they're the pharmacist, they're the doctor, they're the social worker. So that's the useful purpose part. You have to get the right champions, so when you think, well, who do we have in pharmacy that might buy into this idea? Who do we have in social work? You might have some minds that, some names that come to mind naturally. You might have to create some of those champions by talking people into that. And then the idea is to go in there with what you define as the right mindset. So for us is we stress highly high reliability team skills, so that they know they can recognize when they're part of a high reliability team. They can recognize when they're not part of a high reliability team, and they can troubleshoot that, and they know how to correct it. They can recognize when one of the team members isn't firing on all cylinders, and they can address that issue, because everything in healthcare is teamwork. And as I made rounds, every time I went to a different patient bedside, I had a different team. I had a different nurse, I had a different physical therapist, I had a different patient. So you have to recruit their help. The champions will help you to get the preceptor buy-in. What I have found is that the preceptor buy-in, once you get the program started, is really quite easy. If they go on a visit as a preceptor, they instantly see the value in it. If they're the primary care physician whose patient was visited and they get extra information that they didn't have otherwise, information that has been derived, such as, a patient had been thought to be non-compliant with their antihypertensive regimen, and she kept insisting she was until a social work has the knowledge to ask, can you tell me how you're taking your medication? And it said to take the medication 3 times a day with meals. So she says, I'm taking it with meals, but I can only afford to eat once a day. So then the problem became not one of non-compliance, it became the true problem underneath gets identified as food insecurity. And then the social work people can go to work on that, and the situation can be benefit. Once the people at the primary care center see things like that happening, they inherently and immediately see the value in it, and they start relying and referring. They'll say, geez, I have a patient that I think I don't understand completely. Maybe they could visit. And we could benefit from an IPE visit to that patient's house. Part of it, as you heard, I also do some financial work. I'm involved in the business end of surgery. So you have to sell this to your administration. Because if you're going to ask for some resources, they're going to want to know, well, what's the return on investment? So we identified patient cohorts. We identified the people that had frequent visits to the emergency room and people that had just been discharged from the hospital that we wanted to avoid readmissions on, because both frequent visits and readmissions are costly to the hospital. So we told them we would study the effects or the ability to reduce those frequent readmissions and those ED visits. So that's one idea, but find some kind of patient cohort that you could measure something in and that you could sell to your administration. And then the rest of it becomes logistics of how to set this up and debriefing. And I'm going to turn it over to Frank to talk about the rest of this.
Okay, so hopefully by now you folks have got a couple of notes under begin and establish, because we're going to use those in just a moment. When you begin your program, a lot of the purpose behind what you're doing in IPE should determine and impact what to study. As we saw with this morning, they had certain metrics they were trying to meet, certain things they were trying to take into account. You can use your patient health outcomes. If you're trying to meet certain metrics, you can use that to sell that to the administration. I know for us, the student reflections are a large component. That qualitative data that you get back from the students to really parse out what are the themes that we're seeing here, how can we address that? And then when you have your debrief sessions, you can look at that, begin to develop those themes even further as you get their actual, the meeting, get everybody to the table and, okay, what did the pharmacy student see? What did the social work student see? And the medical student. So kind of determine in your mind how you want to study this. What do you want to look at? It should be partly defined by your purpose in doing the program. So do you have a strong enough purpose? Even if you already have a program in existence, where can you go from here? And you can use what you've seen in studying to base that next step. So exactly how to study it. This is the difficulty. There are so many different EMR out there. It's unbelievable. I know in our area, there are several hospitals, different facilities right around. So sometimes getting all that data, there is Health InfoNet, but sometimes it doesn't always make it to where it needs to go. Then comes a complicated component of budgets and funding various research positions. Sometimes that's not an actual tangible option. So we have to kind of figure out how to go about doing that. Sometimes there are difficulties in student accessing Health InfoNet, figuring out what are you going to get that information from. And then you kind of have to go by pilot data versus the complete data. We have a lot of pilot data. We have data that we've gleaned from the different patient cohorts that we work with through Beacon CCT that we can look at and we could say, this population has declined. There are new individuals coming through. It's working. As far as the actual complete data set, it's a little bit more challenging to get a hold of. So I'm sure if some of you have tried to measure that, you can agree. And then transformation. What do you want to do? How do you want to make this work? How do you want to make it work for your system, for your organization? If you don't have a solid why, a solid purpose, you're going to walk to that debrief and you're going to roll your eyes and you're going to say, oh, here we go again. Are the students going to get it? Are they not going to get it? Why am I doing this? Your mindset is so important in determining what your program is going to look like. If you're not solidly bought in, if you're not a champion for this, nobody else is going to be. So purpose, to know your mindset and get your champions on the same wavelength. If you do that, you're going to have a solid foundation towards a real phenomenal program. Our goal is to change healthcare. Whether it's by erosion or attrition, whatever the means are, we want to change healthcare. We want to make this a team environment and make it an interprofessional environment because that's the way healthcare has to be delivered moving forward. There's so much burnout. There are so many different things going on in healthcare right now that we have to develop future interprofessional champions. And these students, they're going to leave our clinics, they're going to leave their third year, fourth year, and they're going out into these real situations. And they might not see interprofessional initiatives. They might not see interprofessional work. They have to be the ones to take that step forward. So with that mindset, we need to continue to push forward with this, develop and expand into new areas. We want higher performing healthcare teams. The only way we're going to do that is by increasing the psychological safety on these teams. And that's by demonstrating importance and value to every member on the team. If you don't feel important, if you don't feel valued, you're not going to collaborate, you're not going to contribute. So often we have med students, tell them, get right out there, go for it, jump right in, both feet. And they do, for the most part. Pharmacy students, they kind of hesitant until they say, I have the med rec, I'm good to go. Social work students, some of them might blend into the background. We need them. We need them at the forefront, contributing and collaborating in the team in order for that to be the highest performing healthcare team as they go out to the patient home. And if the patient sees that, the patient will step up. They'll collaborate because they sense that importance and value, as that's demonstrated throughout the whole team. And then with all of that, our ultimate goal is to exceed the quadruple aim, to ensure that providers are taking care of themselves as well as the patient. Because if you don't take care of yourself, how are you going to take care of somebody else? So what are your goals to transform your organization or your component of healthcare? So hopefully you folks have some ideas written down on that sheet, because we're going to do some work. Okay, so I'm assuming that most people are with folks from your organization. It's all right if it's not fully developed ideas, if they're just seeds of ideas, and anything's up for discussion. We just want you folks to take some time to brainstorm. We'll come around and evaluate your ideas, evaluate the pros and cons, identify champions, cultivate possibilities. So we're going to let you folks, we're going to unleash you on these and get some things going.
So we're going to ask some people to report out on what they talked about at their table.
Hi, we're from the LEND program, Leadership Education in Neurodevelopmental Disabilities, and we were talking with Karen, who knows everything about funding opportunities, and so we were talking about statewide implementation of a audiology screening assessment for young children. And Emily here knows of a device that's used in other states that is not yet used in Maine and could help identify children who have developmental disabilities and might not be able to raise their hand during a traditional audiology exam, but she knows of a device that circumvents that. So we were talking about using that in school systems and working with school nurses and how to fund this expensive device that costs $10,000 and get it into these areas. So it was fun.
And publish the results.
I believe there's actually a breakout session about grants towards those that are IPE inclined.
All right, who else has any ideas about how to start an interprofessional education program where you guys are at, or at your table? There's one table in particular that I know. Oh.
Thank you. So our table was talking about how to better inform and keep our athletes safe, especially the high-risk young female athletes that are at risk for ACL rupture. So to have people that need to research their piece of that puzzle come together to create a sustainable network of sharing information. So the coaches bringing their piece of information to the table about how to train athletes to move, the physical therapist talking about what ways are at risk for injury, the social workers talking about the fear of injury and movement, pharmacists talking about how medicine can play into the risk of injury, so that we're all bringing the knowledge that we already know and having conversations with each other about how that all impacts the patient, and having hopefully not the patient yet, the young athletes, and have the athletes say what they want to learn about to prevent the problem.
Well, that's a great idea, and honestly, we're all patients. Some of us are immediately post an acute event, and some of us are waiting for that acute event. But you know, one of the things that strikes me about your idea is that it's pretty measurable, because you could look at ACL injuries from year to year and see whether your program is having an impact, and that would be something that I would think would have value to the university if they could have fewer athletes injured and so forth. So great.
I kind of stepped into the group while they were still writing, but I conveyed that to have a multidisciplinary approach, or to use all professions, is to start interaction with a person living with chronic pain. That's me. I facilitate the Southern Maine Chronic Pain Support Group, and we interact with students, UNE students, grads, undergrads, and we're expanding it to more professions at UNE. Chris Hall and Ling Sao are the coordinators, and I think this would be a big benefit for the students. Thank you.
So this brings an interesting idea, which we have noticed that really successful interprofessional teams have to incorporate the patient as a member of that team, so that the patient can inform us of what barriers they are experiencing, what they're willing to do to overcome those barriers, and what they're not willing to do to overcome those barriers. Too many times we make plans, both diagnostic and therapeutic plans, for a patient without that information, and then we're surprised when they don't work or they're not followed, and that seems crazy to me. If you don't know the limits of what the field is that you have to play in, how do you succeed? All right, we're out of time. Thank you all for your help and participation, and have a wonderful rest of the afternoon.
I think it's very apt that at the end of the first or the second plenary session that Dr. Hernandez said something to the effect of, why wouldn't we be listening to our patients? The person who's missing on the team, and when we talk about teams, is the patient. And one of the things that we felt very strongly about and feel very strongly about in our interprofessional efforts is how do we do best to bring patients on the team, not just as visitors, not just as guest lecturers, but as truly integrated members of the team. And so that's really what we're going to be talking about. And we're going to have sort of more of a conversation than we are going to have a lecture at you. So just very quickly, I have nothing to disclose, okay? And our goal really today is to give you a little bit of background of why this is important, and then to engage in a conversation with each other. Before I move on, I want to have everybody introduce themselves. So do you want to start, Sue?
Sure. I'm Susan Gold. Oh, sorry. I'm not technology great here, but I'm Susan Gold. Can you hear me? No? Okay. I'm Susan Gold. Yay. I have rheumatoid arthritis. I had undiagnosed pain for about a year and a half. It was excruciating. I started a chronic pain support group in 1993, and it's still going. I turned it over to a great coordinator now, but one of the outcomes of that was that we connected with UNE and worked on their pain project, and then now the group is part of the training for UNE students. And several of us help with talking to pre-med students and letting them know what the patient's needs are. And a lot of them also go to the chronic pain support group and work with them there as well. So we try to have a collaboration and teamwork with the group and with the students here. And I can't say enough about UNE. They've been fabulous in increasing education in patient-oriented, patient-centered medicine. So thank you, UNE.
Oh,
sorry.
My name is Stuart Caswell. I have spastic quadriplegic cerebral palsy, and I also had pretty severe childhood asthma, and I would be in the hospital twice a year from the age of 3 to probably middle school. So I've had a lot of experience with hospitals. And this past April, I was in the hospital for 2.5 weeks. So I've got a lot of experience with stuff.
My name is Shaloa Caswell, and I have been by Stuart Caswell's side since the beginning. And I have seen a huge change in patient, medical professional communication over the last 71 years. Went from a family practitioner who came to our house, I'm the oldest of 5, and treated my siblings And in one case, my mom, who actually got the measles, lined us up, did what they used to do for measles back then, knew us all by name, came to sporting events for the It's a Small Town situation, and Dr. Cowell was really a family friend. And that's back when the population in town was half what it is now. And we had an old-fashioned hospital with a big old boiler that kept breaking down. And I've gone from that in my childhood to just family practitioners who actually, as I grew into an adult and my siblings grew into adulthood, would refer us to specialists once in a great while, depending on what the situation was. And then I gave birth to Stuart and realized just how important that communication with the physician was when I was growing up. The minute he walked in the door, I felt trust, I felt taken care of before he did anything. And it was very difficult getting diagnosis, the proper diagnosis in a timely fashion, and resources and care. It was very difficult when Stu came along all those years later. Then recently, with the recent hospitalization, Stu happens to be home at the moment, and I stayed with him a good part of 2.5 weeks in the hospital just trying to pull information out of the system, and that's what I see now. I see systems, not people, and I think actually that's the other side of the situation now, that a lot of medical professionals see a system rather than people, and it's the same on the other side.
So I have a question up here, and this is really a question for all of us, and I'd like you, as we're talking, if you have some ideas or thoughts that you want to jot down and then maybe share at the end, that would be great. So isn't it time that we really engage patients, families, and communities in interprofessional practice and education? How should that look? How can it happen? And we're committed to making it happen. So we began this conversation in Minneapolis a month ago with clinicians and educators across the country. We're bringing this question to you, and we're gonna chat about it. And I thought the president's story, we were talking about that, about his daughter, also kind of set the tone for this part of this conversation. I know you weren't here, Sue, but talked about a very similar situation. So just to give a context to what we're talking about, because I am an academic and I can't not do that. So who are patients? What do we mean by patients? Because some people don't identify as a patient and yet get a lot of care. So who are we talking about? So these are just, Churchill, Fanning, and Schenck have written a lot about patient identity, patient advocacy, and what they talk about as being a patient is a uniquely interpersonal experience. Hello, there we go. And it requires sometimes a short-term relationship with a provider, or it can be a long-term relationship with a provider, but it is a relationship with a provider. This quote comes from the gentleman who did the painting on the front of your brochure, and I thought what he said is perhaps one of the most powerful statements I've ever heard, which is, the patients are the constant member of the healthcare team. You're shaking your head, Stuart. What do you think about that statement?
I'm just thinking about, the past 40 years that I've been a patient. It's pretty much when you've got a diagnosis of cerebral palsy, it pretty much is your entire life, and a lot of what you have to think about and plan for and all of that stuff.
So do you want to say anything about that?
Yeah, your doctors come and go, especially as you grow older, and the PT people and the dentist and everybody on the healthcare team, they come and go, but you have the same old needs that you have, and they change. Well, they do change. They increase as you grow older too. But yeah, this is your life, and you're the expert on you.
And I think that's the big takeaway, is that given that the team always changes, the constellation, who the people are, shouldn't we be thinking about the patient as the expert in their care? And not only the expert in their care, but an expert in teaching us about what care should look like and what care feels like, and how we can be doing a better job teaching our students about how to be better providers, and working with systems to teach systems about how to provide better care. So that's sort of the slant for today. So what do we mean by patient-centered care? What is patient-centered? And, you know, this is good old Donald Berwick, who talked about it's the experience to the extent the informed individual patient desires it, of transparency, individualization, recognition, respect, dignity, and choice in all matters without exception related to one's person, circumstance, and relationship to healthcare. In other words, after all those words, the patient decides what patient-centered care looks like. And I think the marketing trend has been to call anything patient-centered care these days. But how do patients define it? And how can, again, you tell us about what that should look like? So this is an example of a friend of mine who has a genetic condition called Gaucher syndrome, which causes bone degeneration, terrific pain. Both his siblings died from this very young, and he just happened to luck out to be part of an NIH study that trialed medications to help Gaucher's patients to survive. And he has survived 25 years beyond what he ever thought he would survive. And one of the points he makes is that there's a difference between how providers think about a point of healing and what patients think about as their point of healing. And this was after his hip surgeries, had multiple hip replacements, multiple knee replacements, shoulder replacements. For the provider, the sense of it's healing well, it looks good, it is successful, is a provider barometer of being healed. For the patient, being healed has a lot broader meaning, right?
Yes. Well, the patient's dealing with his or her whole life. So I think you measure how the progress of the healing and how it affects your life. How does it affect your work? I dealt with a lot of chronic pain, so how did the pain affect my work? How did it affect my sleep? How did it affect my relationships, my sexuality? All kinds of things that were important to me. You know, the doc might say, well, this is as far as we can take it for pain, but they're only dealing with, or with I've had 5 joint replacements, so yeah, the joint works okay, but I still got this pain, and what are we going to do about it? So it's certainly a much more personal view of treatment and success, I guess you'd say.
And that's not to say that anyone who hasn't had the experiences that these guys have had and some of our other patients have had should totally understand it. It's more asking the questions and not saying, oh, well, but your x-rays look great, everything looks great, you know. To ask, well, what does healing mean to you? You know, what can we do to take you to a different point, or just even listening. So the goal is the balance. The goal is, when is it time for the provider to lead, and when is it time for the provider to step back? When do patients want to lean? When do they want to be real advocates and in charge and have agency in their care? And that's the delicate intersection that we want to understand, is how do we work together to make that happen. So I'm going to skip this because Jeff Nevers did such a fantastic job of already talking about that. So one of our first questions is patients as co-designers and instructors in health education in practice. What is the right time? What is the right mix? So and I gave you questions ahead of time to ponder this, but so what do you think about being involved in health education? What has your experience been in being an educator, being an informant, and what more could we be doing? How could we be doing this better so we educate a better healthcare workforce?
A couple of years ago, I used to live in Denver, and a couple of friends of mine who also had CP went to, I don't know what you would call it, maybe a clinical with other, like probably first year physical therapy students, and they had us go through an entire physical therapy session. And it was kind of weird. I felt like I was in a movie of like an alien abduction, because I'm lying on my back looking up and there's 12 PT students all around me, and they're hanging on every word that I'm saying. And so I thought that was a really, wow, feedback. I thought that was a really great thing, because they were asking every question in the book, and they were, troubleshooting and all kinds of stuff. And they asked me about my entire history, and I wish that was the first time I'd ever heard of that kind of thing happen, and I thought it was a great experience for the students to have one-on-one time with the patient instead of reading case study after case study, because you don't really get the full picture with textbooks, interacting one-on-one with patients who have actually gone through their experiences, I think is.
How about as a family member? Because often family members are forgotten in this conversation, and yet, you and Stuart have a relationship as, a
Oh, yes.
Oh, yes. And you have a ton of wisdom about, the perspective as a family member.
I think probably the most
Yep, you're on.
difficult thing for me has been to turn it over to Stuart. I had to do that consciously. And I did that when he was actually in outpatient, and Lord knows, it was a while ago, and I can't remember what, and the desk nurse was asking him about his history, and I opened my mouth to answer the question. She was looking at Stuart, and he started rattling off so much more information than I had in my head about the specifics, the dates, the medication, and I realized that mission accomplished. If somebody was going to listen to Stu, they would learn everything that he knows about himself, and that was a great moment for me. And it still goes on. When he's really sick, as he was last April, really sick, in ICU for 3 days, I found myself in the same role that I was in when he was growing up. And it was uncomfortable for me because the doctors, the nurses, the lab technicians, everybody involved in his care were talking to me again. And I just felt like he was still able to talk and answer questions, that please talk to him. He's the patient. And we both actually had an opportunity at this particular point in the admission to ask questions, but then to get the answers involved cultures that wouldn't be back for 3 days. And then after 3 days, we'd ask again, oh yeah, they came in yesterday and they were negative, or whatever. It was just a constant battle of information. And finally, one night, Stu was having some real problem with what the doctor had told him to be a procedure that he didn't need, and a nurse came in and started, and it happened to be drawing blood. more blood. And the doctor had not, as far as Stuart knew, he's alone in the room, and she told him, you know, basically she felt that one reason he had an infection was because the IV was...
Yeah, I had a central line, and she thought the central line was...
And she was just kind of taking it over. So he called me, and I said, look, you handle it. You're there. And he did. He called another nurse in, and she was taken off the floor to treat him again because she was not appropriate. But I think, again, it's the patient needs somebody when they're not able. But when they're able for a question to be answered or an opinion, how do you feel? How do you think this happened or whatever? I think it's important to ask the patient. And I have to believe that, you know, every patient knows themselves. And if they're able to communicate that information, it should come from them. And they probably...
I had a lot of experiences like that. Like, I was in my room watching Jeopardy, and all of a sudden a phlebotomist comes in. He's like, oh, time to take 5 blood cultures now. And I'm like, what the, you know, I thought I was done for the day, you know. And it was a really difficult time getting blood out of me. Like, my veins did not cooperate at all. And he tried for like probably 45 minutes to get blood out of me, and he just couldn't. So my blood pressure shot up, and like it was just a horrible experience. I mean, to get an IV in me, they called up a nurse from the OR, and she couldn't get one started, so they actually had an anesthesiologist come up to start an IV. And after they took my central line out, it was a pretty new nurse, and I don't think she wrote down the note that she changed the tubing in the IV. And at like 1:30 at night, my night nurse came in with an IV caddy and everything, and was like, oh, the nurse didn't write down that she changed the tubing, so we're gonna have to completely start another IV. And I started, you know, I was just like outraged, and I was, you know, and she tried twice to start an IV on me and popped 2 veins. And it was just, and this was all at like 1:30, 2:30 in the morning. So being the director, like, and I told her, you know, all of the history with the OR nurse and the anesthesiologist, and she would not have any. She's like, it's policy, like all of this stuff, and I'm like, well, I need to sleep. I'm exhausted, you know, and I just felt like I didn't have any control at all.
And she was doing her job, but the lack of communication around what happened and listening and honoring what you had to say. But, you know, everyone's doing their job. It's, as you said, it's the system that isn't really working very well. So do you want to make any comment about when, you know, what is the right time and the right mix for patients to become educators and consultants to care?
Well, I've seen the benefits of students interacting with patients. I think it's essential for them to get a first-hand view, just as Stuart was saying, it's rather than out of a book. So we have, at the Pain Support Group, we have a group of students who sign up every semester, and they come in and they go to the support group just as another member would go. They hear all of the interaction and the things that are happening and the concerns. They get to talk with real patients about their own individual problems. So I think that's really very valuable. And I like to think that having us at workshops, at seminars, so that you can get the perspective of the patient. You know, we're all individual, and we all have our own individual perspectives, but I think we can really help you understand what's going on. And I have to say that the best doctor I have in my whole retinue of doctors has a severe neck issue, and he's been hospitalized. And I tell you, he understands my pain a heck of a lot better than anybody else. I'm not saying that you have to go out and injure yourself, but but it certainly helps to have a perspective if you can deal face to face with someone and find out where they're coming from.
So one of the other questions I asked you to think about is how do we do a better job engaging patients in their care? What do we need to do better? What do we need to be teaching for patient engagement?
Just nudge me if I'm hogging it here. One of our chronic pain support members said it best, I think. She said, "Don't just listen to me, hear me." And I think, and my daughter-in-law is a photographer, and she's always telling the kids, eyes on mommy, eyes on mommy. And that's one of my big beefs. If a health professional comes in and looks at through the whole session, is looking at the computer and typing in what I'm saying, they're not interacting with me. I want them to look at me. I want eye contact. I want to know that they're hearing me, not just not just listening. I want them to know that they're understanding what I'm saying. And one thing that I really urge caregivers and healthcare professionals, active listening. If the patient says something, repeat it back to them in your own words so that the patient knows that you're hearing what they're saying. And sometimes you might have misinterpreted what they have said, and then that gives them a chance to correct that misunderstanding. So you're having a back and forth conversation, and everyone is on the same page. There are a couple other things. Patients, especially older patients, may be intimidated by a healthcare professional, a doctor, or they may not understand. I mean, if you're talking jargon or you're using acronyms, they may not understand all that. So you need to talk in the language of the patient, and you need to avoid intimidation. You need to assure the patients that their voice is important, that they're part of the team, that they're an equal, that their self-reports are crucial. And part of that is you have to let them know, and you have to believe that you trust that patient and you believe what they're telling you, because they're not going to share it with you if you're not going to believe them. And I say sometimes I remember when I was in the early stages of my disease and I was in so much pain, it just consumed me. And I'm a pretty strong advocate for myself generally, but I just didn't have the energy. And I tell healthcare professionals, sometimes you have to be a detective. The patient may not have the energy to advocate for themselves. So you need to ask them questions. How is this, what's going on with you? How is it affecting your life? How is it, go through the whole list, because that way you can get a better, and ask them about their life in general. That will give you a better idea of where they're coming from and what their problems are, and you'll be engaging them.
Yeah, I agree with everything you said. Pretty much what she said. My PCP right now, she's great. She has read my chart before she enters the room, and I have edema problems, and she's even gotten down pretty much on her knees, and she's like, let me clip those toenails for you, and she's really, I really feel like she's an engaged member of the team, and that is really important. The doctor-patient relationship is there, but it's so casual and relaxed that I feel like I can tell her anything,
I think it's really ironic that you referred to the PCP as an engaged member of the team when we're talking about how to get the patient more engaged in the team. So it's sort of a little bit of a flip there that was really kind of cool. Yeah. So what about family members? Engaging you, with the right balance. Obviously, you have an adult child. How about when Stu was little and and you were his advocate.
Oh my gosh. We have, is this on?
Keep talking.
Okay. We've had, you know, the saying that it takes a village is just, no, it takes a city sometimes. But we come from a very large, loving family, very supportive. And I think one of my fears early on was, you know, Stu with his CP and a wheelchair, starting kindergarten, I worried, okay, how is this going to be? Well, one of the things Stu did that was different would be if something required applause in the classroom, he didn't have supination, so he clapped like this. I went to a school function in kindergarten, and the kids were performing and everything, and they was a point in time where they all clapped, and they were all clapping like this. All right, that fear's gone. Parents were a little slower to understand that you know, Stu was one of the gang with a slight inconvenience, if you would. And then we'd go to places like the Children's Museum in Boston, and the kids would follow him around after he got out of the wheelchair and got this really cool scooter, and I mean, it was like that tall. And they'd be following him around, asking him when it was their turn. And it just became, everybody knew Stuart well enough in this wonderful neighborhood that we lived in, and both families, that they were just as comfortable having Stu come over and play or stay over or whatever than, you know, just a child without the inconvenience. It was people coming up with ideas, adaptive equipment. I mean, it was a natural thing. It wasn't a focus. It wasn't something written down for goals. Mm-hmm. It was human nature. Yes. And I think as Stu has really benefited, and all the kids that have gone through the same schools, and if given the opportunity to participate, they've received the same loving, welcoming. I mean, I can't say enough about the community and the advantages. I don't think you ever felt like, other than maybe when you got stuck between the water fountains. It's cool. It's like the Volkswagen between the trees. I don't know how he got his scooter stuck between two water fountains, but I mean, once in a while you'd get caught with something, but for the most part, you were just one of the group.
That's great.
Yeah, that's what I saw.
Yep. That's great. So one other question that I asked was, how do you work with patients? And I'm really asking this for you to talk to our audience here. There's a difference between working with a patient and working for a patient. Would you advise to do a better job of working with patients and not just for them? You want to start?
Well, I think you have to view it as every member of the team comes in offering something. The professional has expertise, knowledge in the medical field that you're going to rely on. The patient has intimate knowledge of his or her own body and what the symptoms are and what the problems are. So I think it's just like going to a team of doctors. One is a PT and one is an occupational therapist and one is a family caregiver, a family practitioner, and an orthopedic surgeon. They all have their own strengths, and in that mix is the patient who also has something to offer. So you have to approach the patient as if they do have something to offer, and that you respect what they have to offer, and you want to work with them, not for them. You also want to, and respect goes both ways too. I mean, the patients have a responsibility to work with the team as well, and they have a responsibility to respect the knowledge and experience of the medical team. I say it's not an adversarial relationship, and it should never be an adversarial relationship. Everyone is going to be part of this team, and they're going to be pulling their own weight.
I've had an experience where I had conjunctivitis, and the NP came in, and she was like, "So you got conjunctivitis?" And she just wrote a prescription and left. And it was like, okay, that's odd. But so I think it should be a conversation, as much as possible, It's 50-50, like as what she was saying, the clinician has the education, and we've got the knowledge of ourselves, and the meaning of the two is really the whole package.
So I'm going back to the original big question we have up here, because I realize time is going by really fast, and I want to have the opportunities for you guys to ask questions or to give input. So the question again is, isn't it time, it's really a statement, not a question, isn't it? Isn't it time we really engage patients, families, and communities in interprofessional practice and education? So you ready to get some feedback about that or some input about that from our audience? And are you willing to do some Q&A here? Okay. Bring it on. I actually have 2 microphones. So who would like to ask a question or give some input?
Jeg håber, at vi kan alle sammen huske, at vi ikke her i Maine, vi kommer ikke alle sammen fra USA. Så det er meget vigtigt, at man er åben til at høre fra patienten, at de vi kan lære noget fra dem. Og det håber jeg, at vi alle sammen kan lige huske. Så. Okay. I hope we can all remember that here in Maine, we do not all come from this country. I am an immigrant and did not speak English when I moved to the United States. It is so important that we are open to learning from our patients. There are some things that we may not be familiar with, and the opportunity for us to learn from each other, just as each one of these individuals have stated. So I hope we can help our colleagues to remember that. I practice family medicine in New Mexico. I'm a physician assistant, and I learned so much from First Nations people, from Native Americans. There are certain areas that you do not discuss with certain people. It's the same thing in many different cultures. So if we don't know something, don't hesitate to say to your patient, I would love to learn from you.
And so how do you bring that into the classroom? Because some of us are educators here, and how do you bring that perspective? Because I would agree, we have identifiable different cultures, whether it's language, whether it's race, ethnicity, nationality, heritage. But sometimes we actually have very different cultures, even when we all look the same, right? So how do we begin to think about that from your perspectives as well? What do we bring? How do we bring that to our students? It's a test. If you don't get the answer right, you can't leave. No, see, I'm just putting that out rhetorically to be thinking about, because, those of us in practice, we're doing the work. Those of us who are teaching about practice, we want to do a better job, in part learning from you, and in part, figuring some of this stuff out. Other questions? Yes?
Oh, I was going to respond to your provocative statement. Okay. So how do we bring that to students, was your question. And, as I think about how to be impactful with students, certainly introducing them to people such as yourselves who will tell your story is just so important, because unfortunately, students live in a world of a textbook. And when you open the book, there's a recipe on the page that says, if your patient has A, then you do ... And we obviously need a jumping off point, but healthcare is nuanced, people are nuanced. So I think in addition to helping them learn the recipe, we have to inculcate this constant curiosity so that when our patients walk in the room, wheel in the room, sit before us, we begin to notice nuances. Well, this person appears to be in pain. This person appears to be depressed. This person appears whatever, and begin to quickly sort and think about how does that go with or go against the recipe I learned. And I think for novices, it's hard because you're just hanging on to something. But I'd like to think that as we become more and more skillful, we're able to let go of the recipe card and trust our eyes, trust our senses, trust what we hear, trust our gut, and trust our patients. So, I mean, that's what I would say, is I think we not only need to hang on to our books, but we need to say to students, constantly be curious, ask questions, notice things, look things up. You're never going to stop learning.
Have been since 1994, and I would just encourage us to encourage students to do self-reflection and always think about, is there something that I could have potentially done differently or done better? And self-reflection is sometimes something we forget about.
So I'd like to go back to this question too, and I think for me, listening to you all reminded me of some things that that we could do a better job as those of us in academia working with students and training them. And so Stuart's mom, I'm sorry, I didn't catch your name.
Shaloa.
Say again?
My name is Shaloa.
Shaloa. It's a beautiful name. So you reminded me of what happened in your community with your son, who, you know, authored in his very being, you were educating your peers, Stuart. You were teaching them just by your being about what it means to be a person named Stuart. And so what that inspired was the community being engaged in interprofessional practice and education, and just, it was tangential. But, you know, I think that we could look at our own institutional silos and beyond, say, medical school or nursing school, and go to the next level. And looking at my public health friends, this isn't going to be a surprise to them, but it reminds me as a former school teacher how our people in our communities with different health challenges and their parents were able to educate us all. So we may want to think about going a little higher as we look at our circles of education and practice, so that we remember, for example, schools are the heart of many communities, and that this is a wonderful place for us to be learning how to work with, not just for, patients. And most of us at one time or another are a patient. So, you know, I just made a list of my healthcare team here. So the last thing I just want to say, I'm also reminded of, and I'm not sure who said this, but I think one of you did, of, instead of just walking in and, giving you a diagnosis and a prescription and not even really have a nice day, but, tell me your story. What happened? What's going on? So if we open the conversation with more of a question and less of a immediate answer, then we can elevate this kind of care and remember that healing doesn't always mean cure. So thanks for letting me ramble.
Oh, that wasn't a ramble. That was lovely, Jen. Thank you. So I know it's time to come to an end. I would like to invite all of you to be educators for one more time here. And if you could say one thing to this audience of providers and practitioners and educators and public health folks and all the amazing librarians and all the amazing people in this room, what bit would you like to leave as we think about your role in improving health, education, and health care? No pressure.
I guess I'd just ask you to remember that everyone is an individual. They have their own goals, which are going to influence what kinds of treatment will be best for them. They're more than a collection of ailments. They have a great treasure trove of assets that can help you in your work and that can help you help them. And just encourage you to include patients as the central member of the team.
That's okay. I would, we're humans first, and I think that's the most important thing is everybody has their own story, and they're humans first. They're humans with ailments and not ailments who happen to be human.
Oh, good one.
Thank you.
Very philosophical. Okay. My turn?
Yes.
All right. Can you hear me? I just want to say thank you. Thank you to all of you for doing what you do. I feel very blessed for all the changes I'd like to see happen in the personal care that seems to be slipping away in this age of computers and systems and everything. Without you and all your efforts and your care, I would not have a son. People like you who came before you, I feel very, very thankful to live in this country and to have every prayer answered along this long journey. And there were several times when we could have lost him. And I just keep up the good work, keep learning, and remember, everybody's got a mother.
Well, on that note, I would love to thank you very much for being here today. I know you guys came a pretty long distance, and you came from a meeting with very little time to spare. And I would just want to invite all of you, when you're teaching or when you're in clinic or with your patients, to be open to being educated by your patients and invite patients into not only your classrooms, but think about them when you're writing your syllabi, and think about them when you're putting together programming or whatever it is, because there's a ton of wisdom here that often we're missing in some of the very static curriculum that we have. So I thank you all for staying on such a gorgeous day. And thank you all just in general for being here today. It was very, very special for us. Thanks so much and have a great weekend.